Hello, everyone. Welcome back. We continue our discussion on cerebrovascular disorders, diagnosis, management, and prevention. Today's topic is pharmacotherapy of ischemic cerebrovascular diseases. First, we need to understand the difference between thrombus and an embolus. A thrombus is a clot that adheres to a vessel wall. An embolus is an intravascular clot that floats in the blood. A detached thrombus becomes an embolus. Both may occlude blood vessels and cause ischemia or infarction. Now, arterial thrombosis occurs in medium-sized vessels rendered thrombogenic by atherosclerosis. They consist of a platelet-rich clot. Meanwhile, venous thrombosis is triggered by blood stasis or inappropriate activation of the coagulation cascade. The clots are rich in fibrin with fewer platelets. Let's go to platelet response to vascular injury. Physical trauma to the vascular system initiates a complex system of interactions between platelets, endothelial cells, and the coagulation cascade. This results in the formation of a platelet fibrin plug at the site of injury. The production of an unwanted thrombus involves the same steps as normal clotting, but triggered by a pathologic condition in the vascular system rather than external physical trauma. It all starts with resting platelets. First, chemical mediators are produced by the endothelium. Prostacyclin and nitric oxide are produced by intact endothelial cells. They act as inhibitors of platelet aggregation. Now, prostacyclin or PGI2 binds to platelet membrane receptor, causing synthesis of cyclic AMP. Increased cyclic AMP leads to decreased intracellular calcium. This inhibits platelet activation by stabilizing inactive GP2B3A receptor, preventing the release of platelet aggregation agents. Damaged endothelial cells release less prostacyclin, resulting in lower levels of prostacyclin activating platelets. Now, let's discuss the role of thrombin and thromboxanes and collagen. Platelet membranes contain receptors that bind to thrombin, thromboxane, and expose collagen. Normally, circulating levels of thrombin and thromboxanes are low and collagen is covered by intact endothelium. Corresponding platelet receptors are unoccupied and inactive, and platelet adhesion and aggregation do not occur. When occupied, the receptors trigger a series of reactions that releases intracellular granules by the platelet that lead to platelet aggregation. Second is platelet adhesion. When endothelium is injured, platelets adhere to and virtually cover the exposed collagen of the subendothelium. This triggers a complex series of chemical reactions leading to platelet activation. The third step is platelet activation. Receptors on platelets are activated by collagen of underlying connective tissue. This causes release of platelet granules containing ADP, thromboxane A2, serotonin, platelet activation factors, and thrombin. These mediators bind to platelets and cause them to aggregate. These are mediated by several messenger systems that result in lowered calcium and cyclic AMP concentration. Step 4 is platelet aggregation. Increase in cytosolic calcium that accompanies activation of platelet leads to 1. Release of platelet granules containing serotonin and ADP that activates other platelets. 2. Activation of thromboxane A2 synthesis. And 3. Activation of the glycogen protein or GP receptor that binds fibrinogen and regulates thrombus formation. Fibrinogen, a soluble plasma glycoprotein, simultaneously binds to GP2B3A on separate platelets, resulting in platelet cross-linking and aggregation. This leads to an increased avalanche of platelet aggregation because activated platelets can recruit other platelets. Step 5 is clot formation. Coagulation cascade is stimulated by tissue factors released by injured tissues and mediators from surface of platelets. They form thrombin or factor 2A, a serine protease. Thrombin catalyzes the hydrolysis of fibrinogen to fibrin, which is incorporated into the platelet plug. Cross-linking of the fibrin strands stabilizes the clot and forms a platelet-fibrin clot. And lastly, fibrinolysis. During plug formation, fibrinolytic pathway is locally activated. Plasminogen is enzymatically processed to plasmin or fibrinolysin by plasminogen activators in the tissue. Plasmin limits growth of clots and dissolves fibrin networks as wound heals. Fibrinolytic enzymes are available to treat myocardial infarction, pulmonary emboli, and ischemic strokes. One of the most important drugs used to treat ischemic cerebrovascular disease are antiplatelet drugs or platelet aggregation inhibitors. They decrease formation or the reaction of chemical signals that promote platelet aggregation. The most important platelet aggregator is GP2B3A receptor that ultimately regulates platelet-to-platelet interaction and thrombin formation. Platelet activation agents, thromboxane A2, ADP, thrombin, serotonin, and collagen promote changes in GP2B3A receptor to bind to fibrinogen. Platelet aggregation inhibitors either inhibit the cyclooxygenase pathway, COX-1, or block GP2B3A receptors or ADP receptors. Since they have different actions, synergistic or additive effects may be achieved by combining different classes. The most well-known of these platelet aggregation inhibitors is aspirin. First, an overview. Stimulation of platelets by thrombin, collagen, and ADP activates platelet membrane phospholipase that liberate arachidonic acid from membrane phospholipids. Arachidonic acid is converted to prostaglandin H2 by COX-1, which is further metabolized to thromboxane A2 and released into plasma. Thromboxane A2, produced by aggregating platelets, promotes the clumping process to form hemostatic plug. Now, what is the mechanism of action of aspirin? Aspirin inhibits thromboxane A2 synthesis from arachidonic acid by irreversible acetylation of serine, which blocks arachidonic acid to the active site, inhibiting COX-1. It shifts the balance of chemical mediators to prostacyclin, which favors anti-aggregation. Inhibitory effect is rapid, occurring in the portal circulation. This suppression lasts for 7 to 10 days or the life of an anucleate platelet. What are the therapeutic uses of aspirin? First, it is used in the treatment of transient cerebral ischemia, prevent myocardial infarction, and decrease mortality in post-myocardial infarction patients. The recommended dose range is from 81 to 325 mg with side effects depending on the dose given. Next, what are the adverse effects and drug interactions? First, bleeding time is prolonged and side effects include increased incidence of hemorrhagic stroke and gastrointestinal bleeding. It is frequently used with other drugs with anticoagulant properties like heparin or clopidogrel. Non-steroidal anti-inflammatory drugs or NSAIDs like ibuprofen transiently compete for the serine at the catalytic site, so should be taken at least 30 minutes before or 8 hours after aspirin. Now, second is ticlopidine and clopidogrel. Their mechanism of action is as follows. 1. It irreversibly inhibits the binding of ADP to its receptor in the platelet. It inhibits the activation of GP2B3A receptors required for platelet to bind with fibrinogen. Now, let's discuss the therapeutic use of ticlopidine. It is used in the prevention of TIA and strokes for patients with previous cerebral thrombotic events. It is also used as adjunct therapy with aspirin to decrease stent thrombosis after coronary stent embolism. And lastly, side effects include life-threatening hematologic abnormalities like neutropenia and granulocytosis, thrombotic thrombocytopenic purpura or TTP, and aplastic anemia. What about the therapeutic use of clopidogrel? It is used in the prevention of atherosclerotic events following recent myocardial infarction, stroke, or peripheral arterial disease. It is used in the prophylaxis of thrombotic event in acute coronary syndrome, for example, unstable angina or non-Q-wave myocardial infarction. It is used to prevent thrombotic event associated with percutaneous coronary intervention. It is the preferred agent in ischemic heart disease. It has less side effect than ticlopidine, but can also cause DTP. What about pharmacokinetics? 1. Food interferes with absorption of ticlopidine, but not clopidogrel. 2. Both drugs are extremely bound to plasma proteins. 3. Hepatic metabolism is by cytochrome P450 to active metabolites. 4. Maximum effect is in 3 to 5 days. 5. Elimination is by both renal and fecal route. And lastly, they interfere with the metabolism of drugs like phenytoin, tolbutamide, warfarin, duvastatin, and tamoxifen. Third is abciximab, a chimeric monoclonal antibody that blocks GP2A3B receptor on activated platelets. It is composed of a constant region of a human immunoglobulin joined to the FAB fragment of murine monoclonal antibody against the GP2A3B receptor complex. It binds to GP2A3B receptor, blocking binding to fibrinogen and von Willebrand factor, preventing platelet aggregation. It is given intravenously with aspirin or heparin as an adjunct to percutaneous coronary intervention. Its antiplatelet effects persist for 24 to 48 hours after transfusion before returning to normal. Its major adverse effect is the potential for bleeding. Fourth is eptifibatide and tirofiban. Both drugs block GP2A3B receptor on activated platelets. They bind to GP2A3B receptors at the site that interacts with the arginine-glycine aspartic acid sequence in fibrinogen. There is decreased incidence of thrombotic complications in acute coronary syndrome. It is available as IV solutions since oral forms are too toxic. It is cleared within 4 hours after infusion is stopped. Its major adverse effect is bleeding. Eptifibatide and its metabolite is eliminated by the kidneys. Meanwhile, tirofiban is eliminated unchanged by the kidneys. And lastly, dipyridamole. It is a coronary vasodilator used prophylactically to treat angina pectoris. It is usually given in combination with aspirin and warfarin and is ineffective when used alone. It increases intracellular release of cyclic AMP by inhibiting cyclic nucleotide phosphodiesterase, resulting in decreased thromboxane A2 synthesis. It potentiates the effect of prostacyclin to antagonize platelet stickiness and decrease platelet adhesion. And lastly, in combination with warfarin, it is effective in inhibiting embolization from prosthetic heart valves. Let's discuss blood coagulation next. The coagulation cascade is composed of the intrinsic and extrinsic pathway. The extrinsic system is initiated by activation factor 7 by tissue factor or thromboplastin. It is the more important system in vivo. Tissue factor is lipoprotein expressed by activated endothelial cells, activated leukocytes, subendothelial fibroblasts, and subendothelial smooth muscle cells. The intrinsic system is initiated by activation of factor 12 following contact with charged surface of phospholipids. Now, how is fibrin formed? Now, both systems are involved in a cascade of enzyme reactions that sequentially activates their proenzyme forms to enzymes, eventually activating factor 10A, which converts prothrombin, factor 2, to thrombin, factor 2A. Thrombin is responsible for the generation of fibrin, the glycoprotein that forms the mesh-like protein matrix of the blood clots. If thrombin is not formed or its function is impeded by antithrombin 3, for example, coagulation is inhibited. 1 unit of factor 10 can potentially generate 40 units of thrombin. Now, what is the role of cell surface on coagulation? Its reaction in the coagulation cascade takes place at the localized activated cell surface where a phospholipid-based protein-to-protein complex has formed. The complex consists of membrane surfaces provided by 1. Phospholipid, primarily phosphatidylserine, of activated platelets or activated endothelial cells. 2. An enzyme, which is an activated coagulation factor. 3. A substrate, which is the proenzyme of the downstream coagulation factor. And lastly, a cofactor, in this case, calcium. These factors are essential to bridging the anionic phospholipids and gamma-carboxyglutamic acid residues of the clotting factors. Removal of calcium with calcium chelators, such as ethylene diamine tetraacetic acid, also known as EDTA, or citrate, is used to prevent clotting in the test tube. And lastly are the inhibitors of coagulation. Coagulation should be restricted to the local site of injury. Endogenous inhibitors of coagulation includes protein C, protein S, antithrombin 3, and tissue factor pathway inhibitor. The mechanism of action of anticoagulation agent include heparin and related products, involves activation of these endogenous inhibitors, primarily antithrombin 3. Now, let's discuss the anticoagulants. They inhibit the action of coagulation factors, example heparin, or they interfere with the synthesis of coagulation factors, for example, vitamin K antagonist. What are the anticoagulants? First, are the thrombin inhibitors, heparin, and low molecular weight heparin. Heparin is an injectable rapidly acting anticoagulant used acutely to interfere with the formation of thrombin. They occur naturally as a macromolecules complex with heparin in mast cells. Unfractionated heparin is a mixture of straight-chain glycosaminoglycans with a wide range of molecular weight. They are strongly acidic because of side chains of sulfate and carboxylic groups. Now, low molecular weight heparins, like enoxaparin, can also act as anticoagulants. They are heterogeneous compounds, one-third unfractionated heparin, produced by chemical or enzymatic depolymerization of unfractionated heparin. They are used as replacement of heparin in many clinical situations due to less adverse effects. They are used in the prevention of venous thrombosis and in the treatment of pulmonary embolism and acute myocardial infarction. What is the mechanism of action of heparin? Its anticoagulant effect is due to its binding on antithrombin 3 with a subsequent rapid deactivation of coagulation factors. Antithrombin 3 is an alpha-globulin that inhibits serine proteases, most importantly factor 2A, thrombin, and factor 10A. In the absence of heparin, antithrombin 3 reacts very slowly with thrombin and factor 10A. Heparin interaction with antithrombin 3 accelerates its rate of action 1,000-fold. Heparin acts as a catalytic template for the interaction of antithrombin 3 and activated coagulation factors. What about the mechanism of action of low molecular weight heparins? It also binds with antithrombin 3 and inactivates factor 10A, including those on platelet surface, but not as avidly with thrombin. Therefore, it is less likely to activate resting platelets. What are their therapeutic use? 1. Both limit expansion of thrombi by preventing fibrin formation. 2. They are the major therapeutic drug for treatment of acute deep vein thrombosis and pulmonary embolism. 3. The incidence of recurrent thromboembolism is decreased. 4. They are used prophylactically to prevent post-operative venous thrombosis in patients undergoing elective surgery or in acute phase of myocardial infarction. 5th, they are the anticoagulants of choice for treating pregnant women with prosthetic heart valves or venous thrombosis because they do not cross the placenta due to their large size and negative charge. 6. Heparin has the advantage of rapid onset of action, which is terminated rapidly on suspension of therapy. Lastly, low molecular weight heparins like enoxaparin and dalteparin do not require the same intense monitoring that heparin needs and saves on laboratory costs and nursing care. What about the pharmacokinetics of thrombin inhibitors? First, absorption. The anticoagulant effect of heparin occurs within minutes of IV administration and 1 to 2 hours after a subcutaneous injection. Low molecular weight heparin's peak effect occurs 4 hours after subcutaneous injection. Heparin is administered parenterally or deep subcutaneous since it does not cross membranes readily. Low molecular weight heparins are administered intracutaneously. Intramuscular injections of heparin are contraindicated due to hematoma formation. Heparin is administered IV as a bolus to achieve immediate anticoagulation, followed by lower doses or continuous infusion for 7 to 10 days. Dosage of heparin should be titrated so that activated partial thromboplastin time is between 1.5 to 2.5 normal levels. Meanwhile, plasma levels and pharmacokinetics of low molecular weight heparins are predictable. However, doses need to be reduced in patients with decreased renal function. What about the fate of thrombin inhibitors? Heparin binds to many proteins in the blood that neutralizes its activity. It is taken up by the monocyte macrophage system where it is depolymerized and desulfated into inactive metabolites. Heparin has a longer half-life in patients with cirrhosis. Heparin and its inactive metabolites and low molecular weight heparins are excreted in the urine and have a longer half-life in renal insufficiency. Both heparin and low molecular weight heparins do not cross the placental barrier. Half-life of heparin is about 1.5 hours, while low molecular weight heparin have half-lives of 3 to 7 hours. Now, what are the adverse effects of thrombin inhibitors? First is bleeding complications. The chief complication is hemorrhage, and careful monitoring of bleeding time is required. Hemorrhage is managed by seizing heparin and administering protamine sulfate. Infused slowly, protamine sulfate combines ionically with heparin to form a stable 1:1 inactive complex. Dosage of protamine must be carefully titrated, 1 milligram for every 100 units of heparin, because it is a weak anticoagulant and can cause bleeding if given in excess. 2 are hypersensitivity reactions. Heparin is made from porcine sources and may be antigenic. Adverse effects include chills, fever, urticaria, or anaphylactic shock. Third is thrombosis. Chronic or intermittent administration can lead to a reduction in antithrombin 3 activity, resulting in decreased deactivation of clotting factors, causing increased thrombosis. Low-dose insulin therapy is used to minimize this risk. Fourth is thrombocytopenia. This is a condition where circulating blood contains an abnormally small number of platelets. Heparin-induced thrombocytopenia, or HIT, is caused by heparin and of two types. Type 1 usually occurs in the first 5 days of treatment and is not serious. Type 2, where platelet activated by IgG-mediated reaction with heparin factor 4 complex causes platelet aggregation and release of contents. This results in thrombocytopenia and thrombosis on the 5th to 14th day of treatment and can range from mild to life-threatening. Platelet counts can drop 50% or more, and thromboembolic complications can develop. Heparin therapy should be discontinued and replaced with lepirubin or argatroban. 5. Heparin may result in abnormal liver function tests or osteoporosis. Lastly, contraindications include hypersensitivity, bleeding disorders, alcoholics, and having surgery or recent surgery of the brain, eye, or spinal cord. Another anticoagulant are vitamin K antagonists. First, an overview. The coumarin anticoagulants, like warfarin and dicumarol, antagonizes cofactor function of vitamin K. Warfarin, initially used as a rodenticide, is now widely used clinically as an oral anticoagulant. With the availability of low molecular weight heparin and other platelet aggregation inhibitors, use of vitamin K antagonists is decreasing. The potential for morbidity makes it imperative to identify patients who are truly at risk for thrombosis. Now, what is the therapeutic use of vitamin K antagonists? Warfarin is used to prevent the progressive or recurrence of deep vein thrombosis or pulmonary embolism after heparin therapy. It is used to prevent thromboembolism during orthopedic or gynecological surgery. It is used prophylactically in patients with acute myocardial infarction, prosthetic heart valves, or chronic atrial fibrillation. What about pharmacokinetics? First, absorption. Warfarin is readily absorbed after oral ingestion with 100% bioavailability. Food delays absorption but does not affect extent of absorption. It is 90% bound to albumin, which prevents diffusion in the cerebrospinal fluid and breast milk. Drugs with higher affinity for albumin binding site, like sulfonamide, can dislodge warfarin and lead to increased activity of warfarin. It crosses the placental barrier easily. Mean half-life is 40 hours, but varies with individuals. Prothrombin time is used to monitor warfarin therapy. The International Normalized Ratio, or INR, is used to correct for variations that would occur with different thromboplastin reagents between different hospitals or different batch of reagents in a single hospital. Next, fate. Warfarin is metabolized by the cytochrome P450 system, and its metabolite is metabolically inactive. After conjugation with glucuronic acid, it is excreted in the urine or stool. Now, what are the adverse effects of vitamin K antagonists? First are bleeding disorders. The most common side effect is hemorrhage. It's important to monitor level of anticoagulation. Minor bleeding is treated with drug withdrawal and vitamin K administration. Severe bleeding requires higher levels of vitamin K given IV. Whole blood frozen plasma and plasma concentrates of blood factors are used to arrest hemorrhage. Skin lesions and necrosis are rare and primarily found in women. Purple toe syndrome, the bluish discoloration, is due to cholesterol emboli from plaques. Disease state can augment response to oral anticoagulant. They include vitamin K deficiency, hepatic disease that impair clotting factor synthesis, and hypermetabolic state that increases consumption of clotting factors. And lastly, contraindications. Warfarin should never be used in pregnancy because it is teratogenic and can cause abortion or birth defects. Now, a third anticoagulant is lepirudin. It is highly specific direct thrombin antagonist. It's a polypeptide closely related to hirudin, a thrombin inhibitor derived from the saliva of a medicinal leech, which is produced in yeast cells by recombinant technology. Only one molecule of lepirudin combined with one molecule of thrombin. Administered intravenously, it is effective in treating heparin-induced thrombocytopenia and other thromboembolic disorders and conditions. It has a half-life of 1 hour, undergoes hydrolysis, and is eliminated in the urine. Major adverse effect is bleeding. It can be aggravated by streptokinase and alteplase. It is important to monitor activated partial thromboplastin time and renal function. A fourth anticoagulant is argatroban. It is a parenteral anticoagulant that directly inhibits thrombin. It is used prophylactically in patients with heparin-induced thrombocytopenia. It is metabolized in the liver and has a half-life of 50 minutes. Hemoglobin, hematocrit, and activated partial thromboplastin time must be monitored. It is metabolized in the liver, so it can be used in patients with renal dysfunction. Major side effects is bleeding. And lastly, fondaparinux. It's the first pentasaccharide anticoagulant that is purely synthetically derived. It is used in the prophylaxis of deep vein thrombosis. It selectively inhibits only factor Xa. It binds to antithrombin 3 and potentiated 300 to 1000 times the neutralizing effects of factor Xa by antithrombin 3. It is well absorbed subcutaneously and needs less monitoring than heparin. It has a half-life of 17 to 21 hours and is eliminated in the urine unchanged. Its major side effect is bleeding. Hello everyone, welcome back. We now come to the end of our discussion on cerebrovascular disorders, diagnosis, management, and prevention. So far, what have we learned? This ends our discussion on the pharmacotherapy of ischemic cerebral diseases.